So, good evening, everyone. My name is Dr. Ahmad Hammoud. I'm a consultant pediatric neurologist at the American Wellness Center. And today our webinar is about genetics and the future of medicine. Okay. Let's start with the outline. We're waiting just a little bit to have the slides ready on Instagram, trying to figure out some technical issues. Sorry, I apologize. We're having technical issues with Instagram. So just we're going to wait 5 minutes, try to see if we can solve this issue. And if not, we're going to continue on Zoom without Instagram. Okay, just give me 5 more minutes and we'll start. Thank you for waiting. We are live on Instagram and on Zoom right now. I think there's a technical issue. We cannot share slides on Instagram. So hopefully, if someone wants to see the slide, they can join the Zoom meeting. If not, we'll probably post them again if someone wants to check them. So again, let me introduce myself again. I'm Dr. Ahmad Hammoud. I'm a consultant pediatric neurologist at the American Wellness Center. And today we're going to discuss genetics and the future of medicine. Okay, so genetics is a really integral part of our treatment of patients when it comes to pediatric neurologists. It's sometimes a key component for achieving the right diagnosis. And sometimes it's the only way we can confirm a diagnosis or refute another diagnosis. Okay, so what I'm going to talk today about, I'm going to talk about the definitions of genetics, the mode of inheritance, examples of genetic testing, and then we're going to discuss real cases and the future of medicine. Now, I'm going to start with the definition of genetics. So genetics, what is genetics in general? And we need to differentiate between genetics and inheritance. So genetics is a disease originating from a specific gene or due to a specific gene mutation or something related to the genetic material. Whereas inheritance is what parents or like our mother or father give to us. So this is the difference between, sometimes I tell the parents, we have it, the disease is genetic, and they tell us, okay, so they got it from us. I say, no, probably this is something new within the child. So it's originating from genetics, but not inherited from you guys. Okay, and we're gonna discuss a little bit more details today. I wish on Instagram we had the slides to show you, but you can always join Zoom and see the slides on Zoom. Okay, so the definition of genetics. Genetics is the study of genes, genetic variation, and the heredity in organisms. So it's the gene, genetic material, and how it's inherited. All of organisms' genetic material, including its genes and other elements that control the activity of those genes, is in the genome. Our collection of genetic material, it's called genome. Everything we have, everything that is written, that why our eyes are brown or our hair is black, or why do we look this way, everything we have that makes us what we are, the blueprint to us, is in our genetic material. An organism's entire DNA is found nearly in all of its cells. So if you take any cell from anyone, it has that genetic material for everything else. That's why when we do genetic testing, we take cells, either from the buccal or we take blood or whatever. We analyze the genetic material found in any cell, and accordingly, we get the results. So the DNA is organized into chromosomes. So this genetic material, this genome, is organized into chromosomes. We have 23 chromosomes, okay, which are in pairs. So the total is 46, but the types of chromosome are 23. How do I simplify this? Imagine you're in a wedding and you're organizing the seating plan for the wedding. You'll have 23 locations. Okay, you have 23 locations, and each location has 2 seats, but they cannot, the ones sitting next to each other cannot be from the same side. They either have to come from the bride's side or from the groom's side. So you have 23 locations. These 23 locations have 2 seats, and every seat has one either from the groom side and the other one from the bride side. So we'll have a total of 46 individuals or 46 chromosomes. These 46 chromosomes, they are sitting in 23 locations, and 1 copy from the mother and 1 copy from the father. Okay, then comes after this, from the 46, the last one, the 23 slot, goes for the sex, either XX and it will be a female, or XY and it would be a male. What is a gene? A gene is a segment on the chromosome. So we have these 23 chromosomes. On the chromosome, it has parts, small fragments. These small fragments are genes, and each gene code for something. Okay, so a gene is a segment on the chromosome that contains instructions for building one or more molecules that help the body work, look or work or function. So in the human body, we have cells, and inside the cells, we have a nucleus, and inside the nucleus, we have the chromosomes. And inside the chromosome, there are multiple genes. So let's talk about, we talk about gene, genetic material, chromosomes. How about inheritance? This is something I addressed in the beginning. Like, how do we say if it's genetic, is it inherited or not? Not all the time, but some diseases have to be inherited. Let me give you an example. We're going to start, so mode of inheritance is the manner in which a genetic trait or disorder is passed from one generation to the other. Okay, the most common modes of inheritance are either autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, mitochondrial, which is rare, a mitochondrial inheritance, we'll talk about it, and sometimes it can be multifactorial. So if we start with the autosomal dominant. So what is autosomal dominant? From the name, dominant means it's strong. So a dominant gene means that you don't need two copies. You need a single copy of the disease, of this mutation to cause the disease. So if, let's say, a father has an autosomal dominant disease, he will give 50% of his children. Half of them might get the disease and half of them might not get it. So one copy of the gene is enough to cause the disease. And this is sometimes can happen de novo. What do we mean by de novo? It means in the single individual during development, a new mutation occurred, and this mutation caused the disease as an autosomal dominant. It was dominant, it caused the disease, and now this individual can start transmitting it to his siblings, to his children or her children. Okay, so it's either it comes from the parent or it can occur as a de novo mutation, a new mutation that started with this individual, and from now on it continues, and he continues on inheriting it. Now the second one, and this is the most common one, and this is related to families. It's the autosomal recessive type. What is autosomal recessive? From the name, recessive means weak, which means a single copy of this chromosome does not cause the disease. You become a carrier. And here, when someone marries, let's say, his cousin, or what we call consanguinity, which means they are related. In their family, they are carriers. He is carrying the disease and she's carrying the disease. They both do not show symptoms of the disease. But if the child, as we said, we are taking one copy from the mother, one copy from the father. If the child takes a copy from the mother, which is a diseased copy, and one copy from the father, a diseased copy, then this autosomal recessive and recessive, they join and form the disease. And this gives the percentage of 25% of children that might be affected. Okay, so two copies of the gene are needed to have the actual disease. Next is X-linked dominant. What is X-linked dominant? We said that the females are XX. They have XX chromosome, which makes the individual turn up to be a female, and XY, which means this fetus or individual grow up into a male. So X-linked dominant, which means on the X chromosome, if this mutation is there, then if, let's say, the father has it, so he's XY, X dominant, he will give them to his daughter, but he does not give to his boys, because he will give the Y to his boys, and the Y does not have a disease. If the mother does not have anything, that the boys will be unaffected, and the girls, because they need two X's, they will take one X with a dominant disease and cause this disease in the individual. Whereas if the mother has it, then she can either give to the boy, because the boy will take a Y from his father, or she can give it to a girl and it shows to the girl. So 50% also of the children, whether boys or girls, will have the disease. How about X-linked recessive? Similar to the X-linked dominant, the father, if the father has it, he will not have any affected child because it's recessive, it's weak. The girl will take the other X, which is normal from the mother, and she will be a carrier. Whereas the father will only give the Y to his children, to his boys, and he'll take a normal X. So he will not have any child who has the disease. Whereas if the mother has an X-linked recessive, then there's a possibility that the boy would be affected because the Y chromosome does not carry any genetic material most of the time. So when she takes the X recessive with the Y, we'll have boys who are affected with the disease. It's complicated. I know it's complicated, but this is something we need to know what type of disease this child had and the possibility of future children having this disease. As for the mitochondrial inheritance, now there's an organelle. An organelle, it's something inside the cytoplasm, inside the cell. It's the energy unit, which is called the mitochondria. Sometimes this mitochondria, this energy unit, we call it the motor or the generator of the cell, can have certain genetic material. In this genetic material, the mother usually transmits it with the egg, with the oocyte, transmits it to her children. So if the mother has it, she'll give all her children this disease, if the disease is in the mitochondria. If the father have it, he will not give mitochondria to his children, so he will not transmit mitochondrial genetic diseases, so he will have children who are unaffected. Now, what about multifactorial? We said there's something called multifactorial. Well, multifactorial diseases refer to diseases having a genesis known to be influenced by both genetic and environment, which means he has the tendency, he has the genetic material to develop a disease, but needs certain environmental factors to cause this disease. One of these examples is diabetes mellitus type 1, or what we call insulin-dependent diabetes mellitus. Someone has diabetes who takes insulin. We know that there's a genetic factor for it, but there should be also, it's not 100% genetic, there's also environmental factors that will add up and cause this. Now, let me talk a little bit about examples of genetic testing. So examples of genetic testing, we have the prenatal genetic testing, or amniocentesis is one of them, whereby the mother is pregnant and we want to know if the child has anything, and then the obstetrician of the mother will tell her, let's take from the amniotic fluid, they aspirate from the fluid around the baby and analyze the genetic material, and this will give us a picture if there's anything wrong with the child. Now, if the child is later born, we can do something called neonatal screening, and I'll talk about it later. If we suspect some sort of syndrome that has to do with duplication, which means an extra chromosome or deletion, missing chromosome, then we'll do karyotype. And then there's the new advanced techniques, which are the whole exome sequencing and the whole genome sequencing that we're currently using to specify which gene is mutated and accordingly know what we have as a disease. So I've had a lot of questions from parents saying that, okay, why does my child have genetic disease? We already did this prick from the heel, which is the genetic test. They told us this is genetic testing at birth, and it was negative. It showed nothing. Well, this is called neonatal screening. And from its name, it screens for certain diseases that can be or should be targeted early on in life. So it does not have all the diseases, specific diseases like hypothyroidism, like thalassemia, like let's say G6PD, or some metabolic diseases like phenylketonuria or whatever, which needs specific formula or else the brain will get damaged. Okay, so these tests, the screening test is very important to know about preventive or how to prevent certain diseases that might occur, but it's very limited to specific number of diseases. Okay, this does not mean if you had this test done at birth, then you've screened all genetic or all possibilities. These are mainly metabolic or mainly something that can be avoided or should be managed at birth. How about karyotype? So karyotype is, as I said, there is the seating plan and has 2 copies of one from the mother, one from the father, and it just puts them in front of you as if someone gave you the seating plan. So you look at the chromosome and see, oh, here's 2, 2, 2, 2 in 23 locations. But sometimes, like trisomy 21, which is known as Down syndrome, you can have 1 chromosome from the side of the father, but then imagine someone at the wedding coming and bringing her child with her. Okay, so you'll have 3 individuals in this seating plan. Having 3 chromosomes in this location, it's called a trisomy. A trisomy means the 3 chromosomes of the same number. If it's trisomy at the chromosome level of 21, then it's trisomy 21, or also known as Down syndrome. What about whole exome sequencing? What are we talking about? What's whole exome sequencing? When do we do it? How do we do it? So whole exome sequencing is a widely used next generation sequencing method that involves sequencing the protein coding regions of the genome. The human genetic material is isolated into parts, which are either introns or exons. Now, the exons, when we say whole exome sequencing, the exons are 2% of the whole genetic material. So it's a little small part to analyze, yet contains 85% of the genetic material. So it's very efficient to analyze this. We look into these small fragments, 2% of the whole genetic material, but will give us answer up to 85% of the genetic material. Okay, so exome sequencing can be efficiently identify coding variant across broad range of applications, including population, genetics, genetic diseases, and cancer studies. So we're using these small parts that have a lot of genetic material to try to figure out what type of disease that we have. If we didn't find anything, or we're thinking of expanding it more, we go into what we call whole genome sequencing. So as we said, there's introns and exons. 85% are in the exon, but we still have 15%. This 15% is covered by whole genome sequencing, and usually whole genome sequencing is more or less used as a preventive or prophylactic management. Like you'll do it and find everything you want to know about your body, your tendency to develop cancer, your are you a potential risk for heart disease? Would you have hypertension? So the whole genome sequencing will tell you what you're prone to have, and accordingly you can look out for expected symptoms earlier before you go deeper into the disease. Now I want to discuss a few cases on how I use specifically the whole exome sequencing in order to make the diagnosis. Okay, so my first case, it's a 9-year-old girl. Since birth, she had seizures. She has a small head circumference. She has developmental delay, and she had no clear diagnosis. According to the mother, they told her she has cerebral palsy, but her history does not really confirm cerebral palsy. So cerebral palsy is when someone sustains hypoxic brain injury at birth. She did not have anything at birth. She was developing normally. Her parents are not related. They are non-consanguineous. So what does she have? So when I saw her, I suspected a syndrome, a specific syndrome called Rett syndrome. Okay, and this Rett syndrome is specific for a mutation called MECP2 gene. So I told the mother, most probably this is Rett syndrome, and we're going to do whole exome sequencing, trying to figure out the MECP2. Now, in the past, we used just to send this mutation for MECP2. I will go and tell them, please look at the MECP2 gene, tell me if they're Rett or not, and the answer will be yes or no. So here, what if I was wrong and this genetic mutation that we sent and it took, like, let's say a month, comes back as negative? What do I do next? So it's better to do whole exome sequencing. And if during this sequencing they found a mutation in MECP2, then this confirms my diagnosis. If not, then what is the other gene that's mutated? In this case, the MECP2 gene was normal, but we found another gene called the CDKL5 gene mutation, which was previously known as atypical Rett. So I suspected Rett, but it turned out not to be the typical mutation for Rett. It's an atypical form of Rett called CDKL5 gene mutation, which later on became its own disease. Now they do not call it as Rett syndrome or atypical Rett, they call it CDKL5 gene mutation. And why is that important to us? Because at that time, we knew there was a new treatment for Rett syndrome, and I didn't want to start the treatment before I had an official diagnosis. And apparently, there's no MECP2 mutation. There was a CDKL5. And we discovered that for CDKL5, there's a new treatment approach, which is called ganaxolone, which is a treatment for seizures associated with CDKL5. So now we knew what the diagnosis is, and if we needed to use a medication, we have a specific medication for this specific mutation. The other case, case 2, this was a 3-month-old girl with new onset seizures. So 3-month-old, imagine a healthy 3-month-old starting to have seizures. Okay, she was developmentally normal. And through history, we found out that the father, when he was young, for a period of almost 1 week, he had seizures. But no one recalled that. We had to dig and ask the grandparent, and the grandmother recalled that for 1 week he had seizures. Okay, he did not respond first to treatment, the child. When we started her on a treatment for her seizure, we started her on a medication called levetiracetam, also known as Capra. She did not respond. So here we were thinking, what do we have? Do we have, because we were suspecting a more of a benign type, or what we call a self-limiting type, not a severe form of epilepsy. In fact, it was a very mild form of epilepsy, yet we could not control her with medication. So when we did the whole exome sequencing, we were suspecting this benign, an entity called benign familial infantile epilepsy. So after we did the whole exome sequencing, we found a mutation called PRRT2 gene. And this PRRT2 gene mutation told us, yes, you're right. This is benign familial infantile epilepsy. But I was like, why didn't this type respond to medication? And then we found out that this specific mutation is resistant to this medication. So it wasn't a bad epilepsy type. It was just that this mutation does not respond to this treatment. So we simply switched to another treatment and we controlled the seizure. And for 2 years, we followed up the patient. She was completely seizure-free. And we know now that this case, benign familial infantile epilepsy, when they reach the age of 2 years, the seizures will go away. So when this child reached the age of 2 years, we tapered the medication, stopped the medication, and currently she has no more seizures and she's off medication. The last case is not as doesn't have a happy ending as the case that I just described. So this was a 1-month-old boy started to have seizures. Now I was hoping that this would be a child similar to the previous one, whereby if we just change the medication, we would control it. But he was not controlled on multiple medication. He also had severe reflux, so we weren't sure, and his seizures were more of a tense type. We weren't sure that is he having reflux, acid reflux, or is he having seizures, because he also wasn't responding well to medication. And the EEG we did was not conclusive. The EEG, the electroencephalogram, trying to figure out if there's seizures, we couldn't really find anything, and he had previous readings which were normal. So we did the whole exome sequencing, and the result came back. Not only once, we did it twice. Came back with a mutation called STXBP1 mutation, and this mutation causes severe types of epilepsy. Now, hopefully, sometimes this genetic mutation might not show severe symptom. So it depends on how much of this gene is interpreted into the body. So we might have like lesser of symptoms compared to other patients. We hope so. This patient is currently on medication and we're trying to control the seizures. Now keep in mind, all the 3 that I talked to you about, all of them are autosomal dominant. As I told you, it needed a single copy to have this disease. One of them was inherited from the father, the one I told you that the father transmitted it to the child. This is an autosomal dominant disease inherited from the child. But the 2 others had a de novo mutation, which means during their development, an error occurred in a place within the genetic material, causing this disease to occur. Now, these individuals, if they get married, they have a 50% possibility of transmitting this to their children. So I'm going to conclude with the future of medicine. Where are we going with the medicine? So the future of medicine is promising. Doctors in the past, as I said, used to deal with symptoms only, like having seizures, give treatment for seizure, having let's syndromic, let's try to manage his syndrome without knowing the actual cause. In this era of advanced genetic testing, we can use this to know the cause. We can use genetic testing to know the cause, the treatment, and the prognosis, what will happen in the future. Like I told you, this child who was 2 years old, we knew that at 2 years, the seizures will stop based on previous cases. So we decided at 2 years of age to stop the medication. And hopefully in the future, we will be able to identify causes of diseases that we never could understand. One of them is autism. We still could not, based on genetic mutations that we have, we cannot confirm that it's 100% genetic. And if so, we do not know how to treat, because if we can understand what the mutation is and what does it affect, we can, based on this knowledge, try to produce the right management, right treatment, and know the actual prognosis in the future. Thank you. Okay, we have two questions. How genetic disease play a role in transforming diseases like heart disease and diabetes? So as I told you, the main issue with heart disease and diabetes is the early diagnosis sometimes. And as I told you, the whole genome sequencing is currently being used as a preventive medicine, used as preventive medicine. So we can use these genetic advanced genetic testing to try to identify the disease early on, try to manage early on, and by this we gain a better life into the future. Because as you know, especially with diabetes, that as this hyperglycemia or elevated sugar level continue into the future, the more we have high glucose level or high sugar level, the more damage that our body endures. And if we can early on try to stop this elevation of glucose, then we can live a more or less normal life into the future. And also identifying heart disease early on will help us prevent cardiac arrest or death due to heart problems in the future. Now, another question we have is how advanced medicine helps parents to have normal babies if parents have genetic disease. Okay, this is a cool question. So let's say we identify that the father or the mother has a specific disease that might carry on into the kids. Okay, and let's say let's go into the story of we are a mother and a father who are cousins or related, and we know we have a disease in the family. How can we ensure that we do not have diseased children? Now, new medicine and the new approach is trying to choose the right genetic material from the sperm and the oocyte, try to ensure the fertilization that occurs, like the case of IVF. You can choose the embryo, you can have multiple embryos and choose the embryos which are unaffected, and then implant this embryo and ensure that this child will grow up having no disease. Not sure if we have questions on Instagram. I'm trying to see no questions on Zoom. Nothing. Okay. Thank you so much, everyone, and hope to see you in the next lecture. Bye-bye.